assisted dying, I had very strong, and get some support, I had 40% of our membership were on the other side. And so what we needed to do was say we are not about the bill itself, we're about what's right for patients and what's right for general practice and for our general practitioner members. So I don't think there's one thing that would fix it for everybody. I think there will always remain GPs that are firmly against assisted dying for whatever reason, and that's why we would like the opt-in clause, so that they don't feel that they have to be part of it, or they don't have to be part of it. And what we need to do is make sure then on the other side that our patients have the protections they need for the vulnerable. They also have the ability to exert their autonomy and their choice when that is something they want, if this is to become law. So we're looking at the protections for both the GPs and the patients, rather than trying to make everything work with a form of words, because we're aware there will be different opinions, whatever happens.
I mean, I think that's exactly the same for us. Very same. We would our membership. We have strong people in favour and that would really support assisted dying, and an equal number that are opposed. We would want protection for any clinician, particularly nurses, that respect for their decision. And as a college, we would support our members making either decision, and we've been really, really clear on that. I think there could be a potential that the bill will never cover everything, but I think there's something really important as a principle with the bill is around respect for autonomy. When we get it wrong in healthcare, it's usually because we're being paternalistic. And it's really important, whatever safeguards are there, whatever process, whatever system is there, the underlying basis, we believe as a college, has got to be autonomy of individuals and patients as a bedrock. Legally now, patients and people are allowed to make an unwise decision. That's already in the law. So we've just got to be really careful that we don't have such a high threshold that actually the principle of autonomy gets lost. And I think we will never be able to have a bill that covers every risk, every potential. So I think we've got to have strong safeguards, something that is, people have faith in, whatever side they are. That's what I think the bill has got to be able to do. If you're against it, you feel comfortable. If you're for it, you feel safe. And that's the bit that I think the bill needs to try to be able to create. But at the principle, have autonomy and respect for individuals.
And agree from a physicianly perspective as well, with the same principle aspect side of things as well. And we have a breadth of views within our membership as well, and it's really hard when you're having the conversation of how do you make it practically implementable, because if you have one position, then people will want to make it work and others may come up with more things. But I think practically workable, ethically robust, and making sure that compassion and empathy and care for the patient isn't lost along the way because we feel differently about it. And what we want is that if it goes through, we just want to make sure that all those safeguards and protection aspects are there, both for patients but also for our staff, because what we can't have is then people feeling as though they're excluded or not supported along that journey as well.
Thank you. Before I call on Baroness Finlay, Lord Patel, at the end I'll give you another opportunity, and also Baroness Berridge. So, Baroness Finlay.
Yes, thank you. And thank you for coming. And Dr. Mulholland, you raised the issue of a separate service. And that's really interesting because there have been papers written about having a separate service. University of Lancaster, I think, have produced quite a lot of thought on that. And I just wonder, for both, particularly from the hospital end and the nursing end, how you feel that a completely separate service might help, given that currently our hospitals are running at about 90% capacity plus most of the time. We have patients in corridors, as you've said. We have high staff sickness rates because the staff are already pushed beyond the limit, not just to the limit. And I just wonder how you feel that in our current system you could manage patients having lethal drugs in, for example, a 4-bedded ward with curtains drawn round, or with a side room. And if there's such pressure on side rooms at the moment, how would you decide the patient who's perhaps septic or a infection risk to others, or a risk because they're so confused, to move them out in order to move such a patient in? And I'm intrigued at your suggestion of something which is quite separate, because it may also solve the problem. Some people expect this to be done in hospices, and have even suggested hospices would take this over. And yet, as you have said, there is a great deal of fear already around hospices, and they often get labelled as death houses. They did in the past, and I should, forgive me, I should have declared at the beginning of this session that I am a consultant in palliative medicine with a session at Velindre Cancer Centre and an honorary professor of palliative medicine at Cardiff University. Sorry, I apologise for that coming late.
To me?
Yeah, I can follow. No.
Yeah, I think there is a risk of blurring of whatever it is, whether it's a hospital service, a GP service, or hospice. And I think we want to make sure that patients know where they are, that they don't fear that coercion, even within the system, by being in a place that maybe has got a mixed role. If a patient makes a choice, this is going to be an enormous decision for any member of the public to go ahead with. They will have weighed it up. They want to know that their pathway is clear, I think, as well. So I think there's lots of reasons that I talked about earlier, but I think something that is a separate pathway within medicine has got to be probably the best and safest way for patients and clinicians.
So I think I agree in principle of having separation of pathways. However, I think the practical delivery aspect is huge, isn't it? It's so difficult at the moment to, what you don't want is diverting of resources to make one happen at the compromise of another service. And that comes back to, again, the equity of access, support, and we're already under-resourced both from a system perspective but also from our staffing perspective. So, as you said, vacancy rates, not just staff recruitment, retention, but also morale within our workforce is huge, and the moral injury aspect side of things. So, separate pathways, yes, in principle, but then adequate resources to back that up so that one isn't compromising the other. And the last thing I'd want to see is that the palliative care services, which are already under-resourced, the current situation or direction of travel makes that even worse. And we've produced some reports, as you probably know, around the palliative care services this summer, just highlighting that in detail.
I mean, I think whatever pathway, and I agree with my colleagues, it would need to be very carefully thought. It's got to be good quality. You get to die once, and it's got to be done well. And actually, it's heartbreaking if we think that if you were seeking assisted dying, it would be in the middle of a 4-bedded bay in a hospital. That's a failure. So the whole point of this is to do this well, respecting autonomy. So it's got to be both practical, but also brilliant. It's got to be if someone's seeking to die earlier than maybe nature would had intended, it's got to be a comfortable and dignified death. So I think there's just got to be a practical application. But I think if someone's seeking assisted dying, there has to be something in whatever setting that is really done well for the individual and their family. Just being stuck in the middle of a medical ward with alarms going is not what I think this bill intended, or the individual seeking assisted dying would intend. So I think there's got to be practical application, but striving to do this well.
You wanted to come back in, Dr.
Sorry if I just make one more comment that Mumtaz prompted there, that the moral injury, the psychological distress to people that are, it's tough at with palliative care anyway for every person, and within the system there is provision to support those colleagues. Colleagues that are involved in assisted dying will need that and that training as well. But it's not just our clinical colleagues, it's our whole staff. And if it happens in general practice, it's my receptionists, it's the management, it's the administrators. And the conversation, we as a Medical Royal College obviously focus on GPs, but we as the GPs, we're part of a team. Hospitals are part of a team. And if it happened in that side ward, who are the administrators that are having to do it, the pharmacists, everybody else that's coming in and out, the clinical and non-clinical teams?
Could I ask you one more question? With the bill as it's written and from the impact assessment, the panel must hear from and may question the coordinating doctor or the independent doctor And similarly, they must hear from and may question, they don't have to, the person to whom the referral relates to the panel. But from the impact assessment, this could be a very junior doctor that's involved. And I wondered whether you're comfortable with that level of inexperience, or whether you feel that it must be a very experienced doctor, and also whether you feel that actually the nursing staff involved must have the ability to have some input into whatever report goes to the panel, because they're often the person who's been most with the patient. Oh.
I'm afraid we'll have to break for 10 minutes and then come back, please. We're now resuming the session which we were interrupted by for the division, and I'm going to return to Baroness Finlay to put a question which was partly put, but perhaps could be put more fully.
Thank you very much, Lord Chairman, and I apologise. I'm going to repeat it in case we've all forgotten some of it, but it related to the panel. Because the panel must hear from and question the coordinating doctor or the independent doctor, and similarly must hear from or may question the person to whom the referral relates. But they don't have to hear from anybody else at all. They don't have to hear from both doctors. They don't have to hear from nurses who've been involved. They don't have to hear from the GP or anyone else. And I wonder whether you feel comfortable with the role of this doctor actually being potentially a very newly qualified doctor, as outlined in the impact assessment, or whether you feel that there must be much more information gleaned in order for the panel to take a decision. But I'd be interested to know what you feel.
On this one, it's difficult. The whole question of making decisions for assisted dying is against everything that I've been trained in and I've practiced for 30 plus years, because the outcome at the end of life has been we will support and care for you and provide palliative care as best we can in the circumstances. So in my mind, it's a difficult decision. It's something that you would need a lot of evidence and support for, particularly as it comes in as a new service. Who the doctor is, there's often a process of senior decision making in healthcare, whether it's in hospital or general practice, and more difficult decisions are often referred to someone with more qualification or more experience to help this. With a patient in general practice who has got difficult decisions, we often refer back to the colleague that's got the best relationship or knows the patient best to help with those decisions. And so I think whatever way a decision is made, it's going to rely on people that have got the experience to make difficult decisions, the knowledge and the understanding of the patient, and if that requires you to get information from nursing colleagues, from patients' families, from whoever, that's going to be important in that. But then it's also going to be a difficult decision for those that are actually making the final bit, which probably requires some more senior decision making than new people, but that will depend on their training.
And similar to that, I mean, in clinical practice, complex decision making is shared. I mean, we take away the onus from an individual because things can go wrong, and particularly in these kind of critical decision making, what we would see in normal clinical practice is that there's an assessment, follow through, and then a wider MDT discussion around a patient and then what's best for the patient, but involving the patient within that care. So in the way that the bill is currently placed, clinicians being experienced is really important, face-to-face assessments is really important, and then the wider decision making has to be done kind of as a team and shared decision making, and somebody who knows the patient well, and I think that goes back to the continuity, etc., but I think the experience is important together with the shared decision making, and any assessment has to be done face-to-face. I think, panels, remote, not knowing anything, and just faced with paperwork. We were discussing that as an issue previously as well. I think that's so important to have that connection with the individual patients as well.
Yes, I think there is going to be a balance between experience but also skill and ability. So I don't think experience should trump everything, because actually you can have someone very inexperienced that's not a brilliant decision maker. So I think it's the combination of both experience and good decision making. I do think there is a potential, when I looked at this, about the panel, because there's a real potential that the person's voice could be a bit lost in the panel to whom the decision relates. And I think just to rely on paperwork or not having the ability to advocate for yourself, or because I think we all know, you can read something on paper and meet the person, or it's completely different. And I think there's because the worry potentially is if it's just seen as paper, a little bit bureaucratic, people may not feel that the process was fair or totally represented. So I think there's a balance both with safeguards, getting the right people with the right experience, but also the person or the public who's seeking a decision needs to have confidence that they were fully understood and their issues were understood.
Thank you.
Baroness Berridge, and then I'll come to Lord Patel.
Thank you. You've referred mainly to having had training to do with coercion and safeguarding. Now, in the bill, it does refer to the fact that at least the independent doctor will need training in coercion or pressure. Have any of you had training relating to pressure? Not coercion, pressure.
I want to completely understand what you mean. Pressure from ourselves or pressure from other people?
It's not defined in the bill, so I'm afraid I can't help you. We've got no definition in the bill. Yes. You are going to need training, though, in pressure. Have any of you received any training like that? No. Thank you. And particularly to the Royal College of Nursing, you picked up the inconsistency in the bill regarding the conflict between, I think it's now clause 31 and clause 5 in relation to the ability to opt out. Can I just clarify, forgive me if I didn't understand you, are you supporting the opt-in model for your membership? Because you've got quite a global membership, haven't you, from places in the world that are much more religious than the UK?
If we would feel if you wanted to be involved in assisted dying, you'd have to choose to be involved, but then you also have the potential, if you didn't want to get involved and it was happening you or around you, which I couldn't imagine happening, you can opt out. So we want to be absolutely clear that nurses can say, I want nothing to do with it.
Right. And
as they do with abortion, actually.
Thank you. And just finally, having read the bill, it's not clear to me, but maybe I've misunderstood the bill. If you come upon information that leads you to believe that you've not been involved, but you happen upon information that the person has been coerced or pressure put on them or circumstance pressure, is it clear to you the avenue, or maybe it's through your professional body, where you would intervene in this process to raise the alarm and say, stop the panel, there's additional information that is needed?
I mean, I would have, as it currently stands, I think that goes back to a safeguarding process. That there's and personally, I think setting up something completely different. I think a process that's understood since Victoria Colombier. I think keep going with the same process. It's something that does people know to or should know to phone a number, make a referral, and say they've got concerns.
Right. Thank you.
Lord Patel.
Thank you, Lord Chairman. First of all, can I say you GP and nursing referred to community palliative care, and can I support that? From my own experience, it was a brilliant palliative care provided to a member of my family, both from GPs and nurses. So I commend that we need more community palliative care. Can I come back to the question that was just raised about the panel? You made a point that face-to-face decision-making is the best, and I have to agree with that. So how do you think it would work in the current context of the bill if a panel has to make a face-to-face decision? How do you think that would work?
And we haven't... do you want to give this?
Yeah, I guess we don't... what I would presume is that the panel will be informed by the face-to-face assessments of individual experienced clinicians who have been involved with the patient care, and they're part of the panel then. I mean, I appreciate that not every single member of the panel may know the patient.
We're talking about the panel speaking to the clinicians who were involved.
Yes, or the teams involved.
Or the teams
and
involved.
with a representative who've informed them following assessments in that way. I think that was my how I envisaged it to work.
Malone, you're nodding too, yes. So you agree.
I agree. I think, as we talked about, the workload pressures mean that, and the infrequency of this occurring, as the panel is unlikely to be on site beside where this decision needs to be made. So it'll be, they need to talk in some way as close to face as possible with those involved in the care.
If I were to use the word pressure, and if I use word coercion, how would you interpret the two?
I think it's grey. That's what we were sort of saying. And again, with regards training and things, I mean, certainly...
Apart from training, how would you regard the two words? Are they the same? Are they different? If they're different, how are they different?
I think well, for me, pressure, how I would say it, coercion feels like it's something over time.
Mm-hmm.
Coercion feels like you get the person to think it's their idea. That's how a simple way I would see coercion is, that you lead someone to feel it's them, whereas pressure feels it's a bit more obvious. And I think you've got to probably know a bit about both.
Very simple question next for each of you. In your everyday work, are you able to decide whether the person, the patient that you're talking to, have a capacity to make a decision or not, even those that are near point of death?
I mean, go on, you start.
I think yes, in the decisions that we're asking people to do. Do you want to have antibiotics near the point of death for your chest infection? Some of my patients will say no, some will say no, I've had enough. I don't need more treatment on that, but that's a straightforward decision. We've talked it through. It's a very different decision.
You make a judgment that they have a capacity to make that decision.
On a straightforward thing that I can explain the risks, the benefits, the outcomes and not. We have a shared decision then. It is not my decision, it is a shared process. I think as the decision gets more complex, the safeguards you need to put in around that increase. And if it's a surgical procedure, we see the long lists of things that patients must have gone through and discussed before they do that. Going through it with assisted dying, you would anticipate the list would be longer and would require a much longer process. But effectively, every person that comes into me wanting me to listen to their chest and give some antibiotics, I'm judging their capacity to ask or take them or not take them as we go along with that.
Either of you make any comments?
So similarly, in hospitals, we do the same. So patients that come in, and the judgment, the clinical judgment would be what's in the best interest of the patients. They are presented with this is a treatment. Now, when there's more complex decision making, which are leading to, so even the Capacity Act as it stands, it assumes capacity, and decision making around that for giving treatment, not giving treatment is one aspect. But then if you're using the same principle to assess a patient to say are they capable, and do they have the capacity to make those decisions about ending their life, that's a separate matter, and that's what we're saying, that we would then want a wider assessment on that. So my clinical judgment...
What wider assessment would you require?
So that's where, I guess our position statement with the Royal College of Psychiatrists was quite clear, that the Mental Capacity Act in itself doesn't give the framework for assessing capacity for this particular aspect. And the wider capacity assessment would be more multidisciplinary, people specifically trained to assess capacity. So I do some capacity assessments for some of my patients, but that would not be
So you're saying that ordinarily all members will not be capable in that situation. Okay, nursing, sir?
Yes, I mean, I think I agree with what's been said. There is an assumed capacity unless shown otherwise, and I think that's the principle of which you would enter this. There is a danger, though, with the capacity, and that's why it does need certain assessments. I used to be a nurse consultant in critical care, and people used to say, well, actually, I've had enough, and then you would get, they're depressed. So there is a fine line between respecting autonomy and actually that assessment, and I think that's why you would have to seek that panel, that second level capacity if required.
Before this session finishes, just 2 points on declarations of interest. Lord Goddard, I think you want to correct what you said earlier.
I need to correct my declaration of interest. I'm in fact the vice chair of the All Parliamentary Group for Choice of Life, Choice of End of Life. And I said things down there, the Secretariat. That's what the study group.
And Bishop of Newcastle, I think you...
Thank you. Yes, I should have said that I have no interests,
Yes.
relevant interests to declare. Thank you.
Yes. There is a little time. I think two people want to come in, Baroness Berger and then Lord Winton.
Sorry, Lord Chairman, do I need to say that I have no relevant interest to declare then? I didn't declare them because I didn't have any.
Same here.
Did you? I can't
I
remember.
didn't declare, but I don't have any.
Yes. Right. Well, Baroness Berger, and then I'll come finally, if I might, to Lord Winston.
Thank you so much. Just also to clarify, I have nothing irrelevant to declare. I have a very short question, just for clarification, and then also a very short question. Professor Ranger, just for complete clarity, you mentioned again just a moment ago about the safeguarding system, and if you can share with us where you think this is already adequately covered in the bill, but if it's not, where you think or how it should be added.
I think there's got to be simple with regard to the referral. So what, in my view, if you've got concerns, that would need to be a referral into. But
Forgive me, but can I just specifically my question? Do you believe it's adequately covered in the bill, or do you believe it's not, and therefore, if not, where it? So you're saying it's not, and therefore it should be added in the referral. Is that?
So I think the basis around you can refer to the safeguarding hub is okay. With regard to extra scrutiny, it comes back to what you said earlier, the what if, once that referral's made,
yes,
and the due diligence in the investigation, that will probably need to be potentially strengthened, or there's the practicality of if a safeguard, if you think someone's being coerced or, being for financial gain or whatever it is, the referral needs to be simple, and I think that should probably stay. It's potentially, once you've made that referral, the investigation into what's actually happened or happening. That happens now in child exploitation or trafficking or whatever, but it will need to be another area that may need extra training. Does that make sense?
Indeed.
Yeah,
thank you so much. Also, in two of your earlier contributions, it was both the Royal College of GPs and Royal College of Physicians, you mentioned the potential serious issue of moral and psychiatric injury of your members, and also applying to the wider staff body. How do you believe that we should support GPs, physicians, nurses, and that wider health staff body if it turns out afterwards somebody has been subject to coercion or pressure? And I'm thinking about some cases that have emerged in other jurisdictions where this has been the case.
I think at the moment, we need to be really honest about the current environment that many clinicians work in now. I think we are becoming incredibly intolerant of mistakes, intolerant of the fact that clinicians are human, and any kind of healthcare is not an exact science. You see people's lives ruined on social media. You see that their career comes to an end. I think this has to stop generally, because I think it's poor for healthcare, and I think it's absolutely vital. It's exactly the same in this circumstance, because I think, sadly, whether we like it or not, we don't keep doctors and nurses safe now, and that's the honest truth. So I think anyone who knows that they're involved in any kind of decision at the moment, if it turns out that there are mistakes happen or there's scrutiny, I think it's very difficult for them now. And I think we've got to put, with or without assisted dying, I think we've got to do better than we're doing.
But forgive me, obviously, on the issue of assisted dying where someone's life has ended, if I could ask specifically in that context, what you think should happen?
I think there will need to be that support, that peer support, that structured,
longitudinal support.
Psychological support, peer review, sessions where they get to reflect, and support. And I think it's important that we recognise that right from the beginning. People are making difficult decisions, and it's not an exact science. It never will be.
There's a degree of
Sorry, can I interrupt? Various people want to ask questions. I think you've had your shot. Lord Winston.
Thank you, Lord Chairman. A very brief question, a very brief answer. I may have misheard because I was at the top end of the table, and actually it's not very good acoustics in this room. I heard the suggestion that a dying patient would have to be removed from a hospice and put into a separate place for treatment. Do you think that is feasible or humane?
Personally, I don't think you'd have to be removed. I don't think. I think it's got to be, but it's got to be whatever process there is, it's just got to keep faith. People have got to recognise that this is about autonomy, and if it is in a palliative care or hospice setting, really clear that that decision for assisted dying comes from the person. It's not a treatment option that will be suggested to you. So if it is in a hospice or someone's home or in a hospital, I think that's important. But the most important thing is that that patients and the public feel safe that this comes from them, not a treatment option that's put to them. So if it means it is in a hospice, I know that would be difficult, but that feels more humane to keep someone where they are. It's about person-centred care.
Thank you.
Can I just pursue that slightly, because the suggestion has been that patients could be moved to a hospice from a busy hospital ward, which cuts slightly across that. But I'm also hearing you say that you don't see this as a treatment option. But if the doctor is raising this with any patient to whom this might be an option, where does that sit in relation to the Montgomery ruling and the requirement that you raise issues that may be options for that patient's management if this is viewed as a treatment option?
I think I'm struggling a little bit with why the patient would be in a hospice if they were going to make another decision, because it would be quite at hospice care is end of life generally, and this is not a process, as I understand the bill at the moment, that can be rushed through. It's not a 2-week process, it's not a 1-week process or an overnight change of mind. It's something that will require time, panels, consideration, a lot of evidence. So I think our argument about a separate service would helpfully separate that. But I wouldn't think that doesn't mean a patient wouldn't die at home if that was their choice. Patients, we know that the majority of patients would like, or people would like to die at home, and that could still be possible under assisted dying or palliative care. The community services are there if the services are there for both. I think the Montgomery ruling is an interesting bit. That's probably going to come much earlier down the line, where as GPs, or nurses in the clinic, we'll be signposting people one way or another. We'll say, these are all your options. You can make choices at any stage, but understand the process that goes with this. So I think it is something that we will have to address, whether through signposting or other ways, but it's not something I would see very close to the end of life at hospice time.
It needs to be a continuous, compassionate process, isn't it? I think, rather than... Sorry, apologies.
I beg your pardon. You wanted to add something?
Yes, sorry, I was just going to add to that, as in, kind of moving end-of-life care is meant to be supportive, compassionate, and what the patient wants. Moving patients from A to B just because a change decision from one aspect or is just not, I feel that it's not the right compassionate thing to do for patients. So what you want is that continuity of care to be preserved, and the care to be preserved in whichever setting the patient chooses it to be. I mean, that's the ideal that we're wishing for, rather than swapping and changing. And again, it's not meant to be a bad thing for the patient. It's meant to be what they want to happen.
Professor Ranger, I think you wanted to add something?
No, I agree with what's said. I think there's something about, I think there will be some grey areas. I think you're right, it will tend to be a plan that that there'll be a lead up to someone's death. But I think with the issue with regard to treatment option, I still think, the whole principle of this is it's got to come from the person. So it's not something that you would suggest, do you want chemotherapy or do you want assisted dying? That is just not. Treatment option is exactly that treatment. This is about the principle that comes back to autonomy. This is one thing that needs to be driven by the person and then facilitated. It's not something you suggest to somebody else. Have you thought of assisted dying? Absolutely not. And I think that's. But if having a good death that's symptoms free, good palliative care should always be a treatment option for everybody. There is a slight difference.
Thank you. Baroness Berridge.
Just following up from your helpful comments, Professor Ranger, about the culture that we are in. And it may be that you need to
Yes,
come
yes.
back on this because it was from evidence in the previous session.
That's got
And we
terribly
had the
interrupted
clarification from Lord Faulkner
Yes,
that without any mental intention,
yes.
if a nurse or doctor inadvertently puts pressure, it might just be through circumstances not providing a hospice bed because it's not defined, and there's no time period, this can be way before terminal diagnosis, inadvertently puts pressure that then induces a person to either make a declaration or self-administer the substance, there can be a prosecution without any mental intention whatsoever with the consent of the DPP, with a sentence of either 14 years or life imprisonment. So it may be that you can't, I hope I've summarised accurately, looking at everybody on the committee, what the evidence was of Lord Faulkner.
I don't think he was saying that with regards to doctors.
It applies, it's a person in clause 34. But so you may want to come back to me after asking your members, but because you're talking about the culture, we now have relatives able to say, blank amount of time before this, they were even diagnosed, there was pressure put on my mother, and they can go to the DPP and ask for a prosecution here.
That's the evidence.
So I don't.
That was his.
I think we've got to be a bit aware of the fact that we've gone well beyond our time now, and there are limits to how far we can engage in that discussion. But Bishop of Newcastle, just very shortly, please. Finally.
Yes, but just very shortly, just picking up on the earlier discussion about inequity and access to palliative care services. I just wondered if our medical professionals think it's unwise to proceed with the bill until we have equity of palliative care access.
That's a difficult question, but actually, if this is driven by autonomy, which I believe the principle of this, when you read what many people asking for this are striving to seek, then whether there's a good palliative care service or not, if the primary driver is autonomy, then actually it probably shouldn't make that much difference, because the primary driver is not pain and symptom control for many people, it's the autonomy. And that whether you've got a good palliative care service or not, if that's the primary driver, then it feels that the two things potentially shouldn't be conflated. That's a difficult question to answer, but
yeah, and our college in our position statement sort of reference in a similar way that patient autonomy choice is really important, and it's the equity of access to all the choices that they would wish to have towards the services for end-of-life care, and that includes very good palliative care, but also other options. So it's equity of the access. We have also, kind of supported and published reports around how the palliative care services in general could be better, but I think that needs to be done in tandem.
It does.
Rather than one following the next.
I agree with that.
Very shortly, please.
Very quickly, we would support that palliative care services aren't deprioritised in any way. We always want to have more for palliative care, but we don't want this to mean that people don't look at palliative care funding and deprioritise it in any way. But we would hand it back to parliamentarians like yourselves to make the decision.
Well, we'll have to leave it there, I'm afraid. You've been extremely patient with us, and I think you also will grasp from the questioning and the amount of questioning you've got right across the committee how valuable we found your presence today, and we're extremely grateful to you. And we end really with those words of thanks, and my final word is do look at the transcript, because it's important to us to know whether it's an accurate reflection of what you're trying to tell us. So thank you all very much indeed. We finished the session at that, and we'll be tomorrow for the next public session at 10:15.